Again, I was here. I'm kind of losing track. It's been over a year now, maybe ago, and it's good to be back. Always enjoy speaking to this group. You're always very attentive and ask a lot of questions, and we just really appreciate that. So, the last time I was here, can I see a show of hands who was here last time? Okay, great. Okay. Well, the last time I spoke, it was very general in terms of what exactly is primary care sports medicine. How is that different than an orthopedic surgeon? How is that different than a primary care doctor? They're kind of somewhere in between what we do. So that was the majority of what I spoke about last time. Today, what I'm going to do is speak about one specific procedure that we do in the knees. And so I brought a knee model with me. And as we go, I'll reference this, and I think that'll help to have a visual to kind of bring all the pieces together. So, again, as Andrea said, I'm Dr. Boyer. I work at Upstate Bone and Joint, which is just across the street. I do primary care sports medicine, which means I'm not a surgeon. I have no desire for anyone in here to have surgery. I have no desire for anyone to have a knee replacement. You can just kind of set that to the side right now, okay? Started in family medicine. I did 3 years of family medicine training, and then I did a 1-year primary care sports medicine fellowship where we focused extensively on the musculoskeletal system as well as the cardiovascular system in terms of endurance events, that sort of thing. And also used a lot of ultrasound techniques. So again, everything I do is non-surgical, minimally invasive, walk in, walk out. But I also do a lot of what a typical orthopedist might do. So I still manage people who have broken bones. If you fall, a lot of my patients are falling on the monkey bars, falling off the monkey bars, or sliding, or doing something like that. If you happen to fall and break a distal radius, one of the long bones in your forearm, we can go ahead and numb you up and push that back in place, put you in a cast, do whatever needs to be done. So a lot of the basic things that you think about in terms of what does an orthopedic doctor do, I do that as well. But I don't go to the OR a couple days a week and do surgery. Instead, I have a procedure time, and we'll speak more about that. So the procedure that I want to speak about is what's called a radiofrequency ablation in the knees. And you probably just said, what did he just say? That didn't mean anything. Well, it didn't mean a lot to me either when I first heard it. I'll be honest with you. This was not something that I did in my fellowship. I wouldn't know anything about the procedure, but I have a couple of partners who came to me one day and said, hey, we've read about this minimally invasive, non-surgical technique for people with chronic knee pain, or even people who've had a total knee and still hurt, and what do you know about it? And so I was honest, and I was told them, I don't really know anything about it, but I'll check it out. It turns out that there's good reason for me not to know anything about it, because this is really not a very old procedure at all. Now, the technology using radio frequency, which is basically just a fancy way of saying we're using radio waves to create heat. Okay, so anytime I say radio frequency, just think about heat. And you know, if you heat up something hot enough, you can burn a little section of it, right? In general, burns are not a good thing unless you can burn something that's carrying pain, or in the heart. Who was here last month? Yeah, I think I heard a cardiologist was here last month who spoke about, right? Does some of this sound familiar? Exactly, yep. So I didn't hear that talk, but I heard it was on atrial fibrillation, and which normally you have an accessory tract, right, with it that is causing excitation of the ventricles when they should not be excited, right? And so he can go in, he uses a much smaller probe, of course, than what we use in the knees, and there's tons of finesse with what he does, and he feeds the catheter up and gets it exactly where that accessory highway is, and then what's he do? Burns it, right? So as you can see, not all burns are a bad thing, and in the hands of a cardiologist who knows exactly where you have an accessory tract that's causing your heart to beat irregularly, then he can go in and burn that tract and get everything, the electricity flowing down the right highway again. So again, just to show you that radio frequency itself is not necessarily a new thing, it's just using this specific technology, and I'll explain even more about it as we go, in the knees for this specific purpose. That's what's sort of a newer application of a technology that's been around for a while. For decades, I would say, they've been using radio frequency in the back. So pain management doctors, neurosurgeons, that sort of thing, they've been using this in the back to help with people who have various diseases and pain syndromes coming from the back. In the knees, it's probably closer to about 3 or 5 years old. So it's really not been that long since they've been doing this particular type of technology in the knee. So that's a little bit of history and a little bit about how I got involved based on what I do in an orthopedic office. So why is there a need for this technology? Why is there a need? First, how many people have ever had knee pain? Okay, so there's a lot of hands. Okay, there's 2 hands up for every person sitting there. Okay, I see. So a lot of people have had knee pain, right? How do we treat knee pain? Well, you progress through a very conservative approach, right? We think about things like over-the-counter pain medicines, right? We think about Tylenol. If you don't have any reason not to take ibuprofen, you can take some coated ibuprofen. If that doesn't work, then you talk to your doctor about maybe a prescription strength pain medicine or a prescription strength topical rub. If that doesn't work, you can think about doing some intra-articular, means that you actually take a needle and you go into the joint and you give a steroid shot. A lot of times that actually works pretty well. Depending on how severe your disease is, though, you may get days, you may get months from that. Once the steroids no longer become effective, that's when we start to use what we call viscosupplementation, or this really thick, viscous gel. Okay, I'll not break HIPAA, but I know some people in this room have had that, and I'll just kind of leave it at that. But we've seen some really good success with using this really thick, viscous gel, injecting that into the knee, and basically what we're trying to do is replenish what a healthy, normal knee makes. But as it gets arthritic, it doesn't make as much, so we use the gel. So we've kind of walked through this progress, and after a certain point, the arthritis becomes so severe that a person may come to myself or one of my partners and say, my knee still hurts. I've done X, Y, and Z, but my knee still hurts. Where do you go from there? Well, one thing you can do is you can have a total knee, right? Now the term total knee is sort of a confusing one, because it's not like they bring you in and cut you here and cut you here and then bring in somebody else's knee, right? If anyone's ever had a total knee done, really what they do is they move the kneecap off to the side, open up your knee here, and they really just take a little bit off here, and then they replace that with a bone on the bottom, or excuse me, a piece of metal on the bottom, piece of metal on the top. So now you no longer have 2 pieces of exposed bone that are rubbing against each other, but you sort of put a cap on the end of each bone to try to protect the nerve endings at the bone that are having so much increased signal because of the weight. Does that make sense? So that's kind of what we think about when a total knee. Now, for quite a few people, they get a total knee after they've progressed through that whole conservative approach. They have a total knee and they do great. You know, maybe 8 out of 10, maybe 9 out of 10, depends on where you are, depends on what kind was used, all those sorts of things. But a lot of people, they do really well. But that still leaves maybe 1 or 2 out of 10 that for some reason have persistent knee pain even after having a total knee. So let me ask you, does anyone in the room have any friends or family who've had a total knee and either didn't get any relief, or their relief was good for 6 months or 2 years and then their pain started coming back? Anybody like that? Okay, so a couple people in the room, I've maybe experienced yourselves. So this is actually another one of the applications for this specific procedure, and this is one that I'm really excited about, because for those folks who've had a total knee but still hurt, there's not a whole lot more that you can really do in that case, right? We can think about chronic pain management or just a brace. There's just not a whole lot. So this procedure was very exciting to me in terms of thinking about something that's non-surgical and something that may actually help someone who's been living with chronic knee pain even though they've already had a total knee replacement. So does that make sense so far? Everyone with me? Okay. So how exactly does it work? So there's actually 2 steps to the process. One is called a genicular block. Now genicular, let me stop there. Genicular just refers to the knee. So anytime you see genu, G-E-N-U, that just refers to the knee. So a geniculate nerve is just referring to a nerve from around the knee, okay? So the first step is to do a genicular nerve block. Now, whenever you think about the term block, that just means we're putting some numbing medicine as close to a nerve as we can without putting it right in the nerve. So again, if anyone's broken a finger, you may have had the doctor put some medicine here and here on each side and then push on it, get it back in place. That's called a digital nerve block. Digital just means referring to the finger. So anytime you hear block, just think about we're putting some numbing medicine as close to a nerve as we can to try to get some relief. Now, anyone who has ever had that, they know 6 hours later what happens. It wakes up, right? And you hope that you have a prescription for some pain medicine, right? Because you just got a hurting put on you, and now your numbing medicine is worn off. So the first step in this process is to do a knee block. So how do we do that? Well, I see in the office, if we've assured that you progress through the appropriate measures but still have pain, then what we do is we have you come over here to the hospital, and I actually do this in the cath lab. Okay, the cath lab, of course, where you get heart catheterization and you might have a pacemaker, but don't worry, I'm not going to be anywhere close to your heart. The cardiologist, the gentleman last week, he can do that. I won't get anywhere closer than about down here. Okay, so what we do is we have you lie on your back, and you're awake during this, and the knee's pointed straight up, and we can use a camera to get pictures from above the knee this way, okay, and then one from the side. And then we use 3 different locations. Now, the people who explored this, looked at the anatomy of it, I think just were really thinking very well, very clearly. They discovered 6 different nerves that carry the pain signal from the knee. So 6 different nerves. But they've also found that through studies, you only have to go after 3 of those 6 to get people sufficient pain relief. So you think, well, that's good. That's better than getting 6 shots. At least now I can get 3 nerve blocks, and that sounds a little bit better. So the places that they've decided to do the block, these 3, are one is up here, one is over here, and one's down here. Now, why do we avoid going to this one here? The reason we avoid this is because there's a big nerve that loops around this bone, the fibula, and then it divides into 2 different branches. And those 2 allow one to lift your foot up like this and one to turn your foot out. Okay? So there's a big motor and sensory branch here that we don't want to get anywhere close to. But it's okay because we found, the people who've done the studies have found that if you go here, here, and here, you can completely avoid the danger of the nerve that lives there and still get patients satisfactory pain relief. Okay? Now, speaking about the nerve that wraps around there, I need to clarify. The nerves in our body are different in terms of some are what we call motor nerves, which send a signal to a muscle, right? And when that nerve signals, it causes the muscle to contract. There's motor nerves, there's purely sensory nerves, which only carry sensory information like temperature, vibration, pain, those sorts of things. And then there's some called mixed, which carry some of each, right? The beautiful thing about this procedure is the nerves that we're targeting are purely sensory nerves, right? So sometimes people will say, well, doc, I don't want to do that because I don't want to have my knee become weaker. The good news is it won't become weaker because we're not going to be anywhere close to the motor nerves. Does that make sense? So this is purely trying to burn a little section of pain nerves. All those nerves do is send a pain signal from the knee up to the brain. Okay? Now, the next part is probably one of the most difficult that I have to try to explain to my patients, in that the block, remember like we talked about, if you get a block and you go home 6 hours later, it wears off, the block is going to wear off. All right? So what I try to explain to people, the medicine that I use what's called Marcaine, which is a little bit longer acting than other medicines. And so what I try to explain to folks is the most important thing is going to be the first 24 hours after I put the medicine in the knee. All right, so you come into the cath lab, you lie on your back, we put the 3 different injections in, and boom, start the time clock. 24 hours. That's what we're going to talk about. When I see you back in the office, that's the most important thing. Because I'll have patients come back and I'll say, how did it work? And they'll say, doc, it didn't work. I felt great for a day or 2 and then my pain came back. And do you see where I'm going with this? That's exactly what we wanted to do. We want your pain up here. You come in, you have the block, your pain drops down, you feel great for 24 hours, it wears off, and your pain comes back. That's exactly what we wanted it to do. And that's one of the most difficult things that I've had in terms of trying to explain how the procedure works. Now, you're thinking, well, why do you do the block first? Why don't you just do the second procedure? Well, keep in mind that even though your x-rays may show a lot of arthritis, there's other reasons to have pain that goes over the knee, right? Has anyone ever had low back pain that went down the leg? Yeah, what we call radicular pain, right? So you may have a nerve in your low back that's being irritated here, but you're having pain in your foot, you're having pain in your knee. Also, you can get referred pain from the hip. So say you have really bad hip arthritis, you may be getting pain that goes down into the knee. So even though the second part of this procedure is minimally invasive, you walk in, you walk out, even though the second part, there's not a whole lot to it, we wouldn't want to progress and do the second part unless we thought there was a very high probability based on the first part that you'd get good relief. Everyone with me so far? Okay, perfect. So I see you in the office, I set you up for the block, we put medicine at 3 different sites around the knee, and this is pretty interesting. The amount of medicine is 1 milliliter. 1 milliliter at 3 different places. So a teaspoon is 5 milliliters, right? So think about that. So we're using less than a teaspoon of medicine at 3 different locations around the knee. And I've seen people literally come back to the office and say they had no pain for 2 days. No pain for 2 days with less than a teaspoon of medicine. And again, I'm not going to break any HIPAA violations. I'm not going to look at Andrea right now. But there are people who can testify to that it really did work. So that's a very small amount of medicine. So what I want you to see is the power of trying to target where exactly that nerve lives in terms of trying to get pain relief. And to think about how small that little electrical wire is that's carrying pain signal from the knee up to the brain. Okay, so 1 milliliter, 3 different locations, and then I see the patient back in a week and say, how do you feel? We give them a little pain chart, and they keep the, from 0 to 10, how bad is their pain? And again, it's the first 24 hours. Now, if someone comes back and says, Doc, I had at least 50% of my pain removed from the block. So again, it's not perfect, it's still medicine, and I can't, remember, directly see the nerves. It's too small for me to see it because I'm using an x-ray. So all I can do is base on bony landmarks where the nerve lives. So we just know based on, however many folks they've looked at, the high likelihood of where that nerve lives. We put the needle there, right? And then we come back. If the person gets at least 50% of their pain relieved, if they want to go on with the second part, then we do. Okay? Then we set you up for the second part of the procedure. Now, the second part is when we actually use the radio waves. All right? So remember, radio waves, the first thing you think about is heat. Exactly, right? So you come in, still in the cath lab, still lying flat on your back, still with the knee pointed straight up like this. We use the same exact 3 locations. Remember, that's logical, right? Because we've already done the block. That was the whole purpose of doing the block first, is to see if there's a high probability that this second part is going to be effective. So we use the same 3 locations. And this time, though, instead of just putting 1 milliliter of medicine at each of those 3 locations, this time we actually use a needle that at the very tip has a radio frequency generator, if you will. So what that does is creates a very small sphere of heat. And so think about a Dum Dum lollipop. Okay, so if this was the holder, right, and the Dum Dum lollipop's on top like a little marble, that marble, and it's not perfectly spherical, but that gives a good indication. That marble is about the size of the sphere of heat energy that if you can get that close enough to the nerve, you can burn the nerve and thereby secondarily decreasing the amount of pain coming from the knee. So instead of your brain hearing, my knee hurts, my knee hurts, my knee hurts, it's going to slow that signal down, if not completely stop it. Now, what are some of the difficulties in the procedure? Well, I mentioned one of them earlier, is that I cannot directly see where the nerve is. It would be so much easier if somehow there was a way to identify the nerve. And I think someday we might, as ultrasound gets better. I think someday we may be able to directly see that. But right now, all I can do is say, well, I know the nerve lives about right in here. I know the nerve lives about in here, and I know there's a third one about here. So what I do is try to get the the radiofrequency probe as close to those areas that I can in hopes that I'm going to get a good burn of the nerve. Now, you may still be in the proper vicinity, but pretend this is the nerve and this is the dum-dum lollipop. What if I'm just kind of like here? I may burn a little bit of the nerve, right? What if I'm just square on it? I may be able to burn the entire caliber or the entire width of the nerve and get a better burn. So as you can see, it's a little bit tricky in terms of exactly how much, and I think that really speaks to why some people come back and say, Doc, I have no pain. Some people come back and say, I think it's about 50% better, and some might even come back, it's not that often, but once in a while somebody comes back and says, I can't tell a difference, all right? They may have had an anatomy that's just different enough that you weren't able to touch the nerve with that sphere of heat. Okay, does that make sense? I know we've covered a lot of ground pretty quickly. Does that all make sense? Okay, great. Now, what are the risks of the procedure? This is one of the parts that I really love. The risks are very low. Even people who are on Coumadin, even people who are on a blood thinner, they can have this. The reason is the major blood vessels that go down the leg, they're in the back of the knee. Remember, how we have you positioned is like this, so the needle is going to come straight down. So if anything, we'd come out, and again, this is just an exaggeration, but we'd come out and we'd hit the table. We wouldn't hit the major blood vessels. Do you see what I mean? So the beautiful thing is we're not close to any major blood vessels, and also the major motor nerve that also we could injure, we don't even go to that site. That's one of the four that we don't go to. So in terms of risks, it's very low. So a person would not have to stop a blood thinner. If they wouldn't have to stop really any other type of treatment that they're on, which has been really helpful, and it's another reason why this procedure is so beneficial, because a lot of people who need this done or need a total knee can't have it because they're too sick to have it. All right, but this procedure can hopefully still afford people some pain relief without having to undergo the different risks and complications that are associated with the total joint replacement, and also the physical therapy that comes afterwards. A lot of times getting the total joint is the easy part. It's the physical therapy afterwards that's very difficult and very painful. So, and then other risks, there's always a risk for infection. Anytime, of course, that you're going through the skin with anything, scalpel or a needle, there's always a risk for infection, but we make sure that area is very clean. We have not seen any infection. And the benefit, we hope, and we've seen thus far in the 6.5 months we've been doing these here at Baptist Easley, is that we'll get people some pain relief. And again, think about it like a bell curve, though. All right, some people over here say, I didn't feel any different, and there's some people over here who feel 100% better, and there's a lot of people in here who feel somewhere between 40 and 80%. Okay, it's like anything in medicine. It's not perfect, but we've seen some very promising results. And each time you do it, you learn more and more about it. And I think over time, the success is just going to continue to get higher and higher. And we have some young folks with us now who've expressed some interest in research, who are going to try to get some better numbers for us in terms of success. So I'm hopeful if you ask me again in 6 months, hey, what's the success that I should hopefully be able to tell you some more specific numbers. Now, one other thing I need to point out is that the nerves that we target do eventually grow back. Okay, so a lot of times we are very hopeful that a nerve is going to grow back. Let's say you're in a car accident or some other type of trauma and you have nerve injury, and the doctor says, well, it takes a long time, but the nerve should grow back. Maybe a millimeter every so often, or every period of time. So in general, we are very pleased that nerves grow back, right? However, in this case, when you purposely want to destroy a nerve, that pesky little nerve grows back, right? Now, how long does it take? Well, again, that answer depends on how much of the nerve you were able to burn originally, right? So if you were able to burn the entire caliber of the nerve, say you burned a couple millimeters of the nerve, you're going to get longer lasting results than if you were only able to burn like half width of the nerve. See what I mean? So I like patients to know that the pain eventually will come back. But the nice thing is you can always repeat the procedure. There's no reason why you couldn't. You still go through the same process. You do the block first, again, to make sure that you can still identify where the anatomy is, because if the nerve grew back, you'd want to make sure, now, can I still get a successful second block? Because if it's grown back, did it take the exact same course, or did it kind of go to the outside around some scar tissue? So you'd still want to do a repeat block, but there's no reason why that you couldn't do a second procedure to try to get the same kind of pain relief again. Well, I think that's about all I had. I was going to open up to questions, if that's okay. Yeah. Yeah.
I had a total knee replacement both knees, and I have metal in the knee.
Uh-huh.
Are you going to tell me that that nerve might go back?
Well, so when it comes to the total replacement, remember, what they did was all on the inside of the joint. So here, they took off a section here, they took off a section here. The nice thing about this procedure is the nerves, where we go, is completely outside where your surgeon did his or her work in your knee. So all of your, if we were to get an x-ray of your knee, we would see hardware here and here, but where this procedure actually targets is on the outside of those locations. So we wouldn't be anywhere close to the metal that's in your knee from the total knee replacement.
So it won't grow back on that, right?
I'm sorry, I can't hear you.
Will it grow back? Can I expect that pain back?
Yes, ma'am. The nerves still. And remember, when they did a total knee, they didn't purposely target those nerves. They just moved the kneecap to the side, and then they just put in their hardware. It's kind of like a trip to Lowe's, if you've ever been to. It's an inch. There's a lot of sawdust in there. Well, they to get access to it, they move it to the side. That's why there's that big vertical incision here. They move it to the side, and then they can open it up and put the new surface on. Yes, ma'am. Yep. Yeah.
Could you have your procedure without having had knee replacement?
Definitely, definitely. So it's a great question. Let me repeat it. So the question was, can you have the procedure without having a knee replacement? Definitely, definitely. All you need to do is make sure that you've progressed through all the appropriate conservative treatments first, meaning you've had over-the-counter medicines, you've had prescription medicines, you've had the steroid injection, that sort of thing, because a lot of those conservative treatments, they work quite well and can keep people going for a long time. So we want to make sure we try the lowest risk, minimally invasive things first. But yes, you're exactly right. This is not just for people who've had total knees. I just like it because it's an option for people who have had total knees but still have pain. That's a great question, yeah.
Will Medicare cover that?
They will. They will. I haven't, to my knowledge, we haven't had any issues with Medicare. Yeah. Medicare's actually been very, very helpful. Yeah.
Yeah, the question I have is now, with my knee, the doctor said that they're going to have to cut me up here and put in a whole new jig, going from the bone clear down through.
Uh-huh.
Now, would that work instead of doing that?
Well, it would be, I'd have to look at your knee to know exactly what they were referring to. But really, it's for any chronic knee pain that's originating from the knee joint itself. You know, it wouldn't be for pain in the femur, in the thigh bone, or lower down. It's really, these 6 nerves are carrying the signal from the capsule that surrounds the knee joint itself. So if it's something outside of that, and that's why I'd have to sit down with you, I'd have to know exactly what they were wanting to do and why.
Well, with mine, what it is, where the knee is going this way across each other.
Uh-huh.
Okay, mine's moved over like a quarter of the way.
Okay.
So that little groove that rides in between the other grooves is sitting on top of it.
It sounds like you're having a maltracking of your kneecap. And sometimes what they do is they do a lateral release and
The kneecap in there.
and move it. What's that?
I don't think the kneecap's in there. It was pushed way back into the joint.
I'll be honest, I'd have to talk to you more to figure that one out. Yep, that's but it's I'd love to. If we could sit down, I'd love to.
Well, I got the x-ray out in the car.
Okay. we can just hold it up to the sunlight, right? Well,
Basically, it's all it does is put it under the skin.
that you were a Boy Scout, I think, right?
No.
That man was prepared. Yeah.
Given that most of the procedures, I'm guessing that you're treating at this point, or the reason for the procedure is non-traumatic injury, rather arthritis.
Right.
Given that you can do what you're doing, in other words, the signals.
Uh-huh.
How long is it, typically how long is it before the arthritis takes over where the joint becomes dysfunctional?
Well, and you know, a lot of times people have already shown some dysfunction of the joint, as you're speaking about, in terms of loss of extension and loss of flexion. A lot of times these folks can't get past 90 degrees. Normally you should get back to 130 or so, 120, 130. So already people are showing evidence for loss of function. They may have loss of stability. You're exactly right though. Trauma can do many things to get the knee out of natural alignment such that you're at an increased likelihood to develop degenerative osteoarthritis.
Given that most people stop the functional rotation because of pain.
Yeah.
Once you take away the pain, does that then allow less dysfunction?
That's a great question. And it's such a key point to keep in mind. This procedure, again, only decreases pain. So if you have a loss of function that's secondary to pain, so if you can't bend the knee back because it hurts to do so, after the procedure, there's a chance you might be able to do that. Now, if you can't bend the knee back because you have a mechanical locking, or if you have a mechanical physical obstruction, then even if you're out of pain, you're not going to be able to do it. Does that help?
Yes, sir.
Okay. Yeah, that's a great question. That's a key thing to remember. This is not to replace a total knee. This is not to improve stability of the knee or improve function. This is really to decrease pain. Yeah.
How long do you wait for the first procedure?
It generally turns out to be about a couple of weeks, but that's just because of scheduling. It's not a, really all you would need is, really you could do the block on Monday and you could do the ablation on Thursday if you wanted to. But it's more because I see you back in the office and I have to have it scheduled. I have scheduled the time in the cath lab and I just have 1/2 day a week. So it's because of those things logistically, but really all we need to do after the block is for me to say, did you get at least half of your pain reduced for at least 24 hours? And as long as that happens, then we can get you set up for the second part. Yeah.
Just curious, when you go in with this radio frequency and hit the nerve, you don't, with that heat, do you hit the bone, the muscle, or the tissue?
Sure, anything that's next to it. Anything that's next to it. But, and I kind of had the same, when I was learning about this, I kind of had the same concern. Well, there's, there's the Pez Bursa there, there's the MCL inserts there, there's the IT band. But we really haven't seen problems with that. It's really interesting, but I thought the same thing. Well, what about all the collateral?
Is it just,
Well, because of, and this is one important point that I didn't mention, this specific technology is called cooled radiofrequency. And the reason that that's important is because of, instead of just having a linear source of radiofrequency energy, this is actually, they send water through the tip of the probe, and the physics are beyond me. But what it creates is more a sphere of radiofrequency. And the beauty of that is, if this is the nerve, you can approach the nerve this way, you can approach the nerve this way, you can approach it this way. Any way you approach the nerve, as long as you get the tip close enough, in theory, you should get a burn because it's a sphere of burn. If it was just linear, then you'd have to basically get it like this, right on top of the nerve to get a good burn. So to answer your question, hopefully that makes more sense. Yes, you're dealing with a sphere of radiofrequency energy, or a sphere of heat. So yes, you would burn what's in that close periphery. Now, where could that become a problem? One is if it negatively impacted the stability of the knee. So if afterwards, if it did something to one of the collateral ligaments, that would be a bad thing. Or if it caused chronic pain afterwards. What's interesting though is after we do the ablation, I generally tell people give it about 2 weeks of having some soreness, because it was a larger needle than the block, and we had to get down next to the bone. It's a catch-22 because you have to get close enough to the bone where the nerve lives to get a good burn. But if you get close enough to the nerve to get a good burn, it hurts, right? Exactly. So it is a bit of a catch-22, but I've not seen that structurally people have a problem, nor have I seen long-term pain from structures around it. If anything, it's still that arthritis, it's still that kind of pain, I'm getting it right here sort of pain. It's not pain at the site that lasts. Does that help? Okay. Yeah. I'm sorry?
Will the procedure work on any other joints in the body?
It sure will. It sure will. We've started with the knees. I'm just kind of waiting for the green light to think about some other places, but those are above my pay grade. But yeah, I think someday we will be able to do that. And actually, I refer routinely. People come to me and they'll be in the situation, and I'll say, you know, I just do knees, but I know a guy in Anderson, or I know a guy in Greenville who does hips, or lumbar spine, or SI joint. I think someday we'll be able to do this in the shoulders, and I think we'll be able to do it with the ultrasound. So I think there's a lot of potential here. But yeah, right now it's just in the knees. But the good news is if, you know, if you came to the office and you wanted the procedure, I can get you to the right person. So, yeah.
I wanted to know, I can't, if I fall, because I had total knee replacement both knees, if I fall down on the floor, I cannot get up. Why is that? Why can't I get up? I mean, why shouldn't I be able to get up?
Well, you know, getting up from a seated position or even on the ground, it requires a lot of quadriceps strength. And depending on, you know, how strong your quadriceps are, that's probably one of the biggest things. If your x-rays of your knees look normal and everything like that, I would say it's probably from core and quadriceps strength. Yeah.
Is the needle that you use to do the burn as big as or bigger than the one that you get shot cortisone straight?
It is. It is. It's probably about 16 gauge, which means that's
The cortisone shot needle is big.
that's a big one, and it depends on who gives it to you. Dr. Robertson's is about like this big. I give you one this size. So if you want, depends on who. No, but seriously though, different providers use different size needles. For a knee injection, you're probably looking at anywhere between 18 and 25. So there's some variance in the size of the needle. This is slightly larger than probably the largest needle that you would routinely have for a knee injection. Does that help? Okay. About 6. Yes. Better. Better not to look. Yeah.
What's that rubber thing down on, is that ligament?
Yes. Yep. So these two are ligaments on the sides, and this is the quadriceps tendon, and it goes over. To, yeah. Yes, ma'am. Quadriceps tendon goes down the patellar tendon. There is some swelling. It's not much though. It's really because it's so deep. It's not close to the surface.
I had arthroscopic years ago.
Yes, ma'am.
If this procedure had been available then, would I have that surgery?
Well, it depends on what was the indication for your surgery originally. If it was for a meniscus tear. Yeah.
But I wouldn't have anything to do with it.
No, ma'am. No. This is again for.
Well, I had pain.
Oh yeah, I believe you. I believe you. But it really depends on what the indication for that procedure was. But it sounds like for yours it was a meniscus tear. So
Yeah.
should I? I'm not sure, Andrew. I'll be happy to do.
Covered by Medicare.
It is. Yeah.
Oh, I'm sorry.
Have you had any dealings with medication in the knee that is called, they make it out of rooster cones?
We do. It's a Supartz. It's a Supartz. It is made out of rooster comb. The major risk that we've had is people get up earlier in the morning.
That's no problem.
And they crow. But otherwise, it's pretty well tolerated.
Hope of my name was giving me that kind of, Dr. Osborne, he went in and put 5 shots in each knee.
Right.
That was some 5 or 6 years ago, and I'm through with that.
Yeah. And that's a great point. That's why we progress through a conservative approach first because some people, like this gentleman, he had great pain relief from the gel. It's a very thick, viscous substance, and if you have pain relief, then you don't need to proceed any farther. This would be in the case that someone's already tried that or something similar to it, and they continue to have pain. This is another option, but that's wonderful. As long as he makes you breakfast, right? Yeah. Yes. I'm sorry? Again, that's a good point. Those, if it's buckling, that's normal because of a structural or a strength issue. Remember, these nerves that we're addressing are purely sensory. So probably the number one, probably the first two reasons that a knee buckles are, one, you could have a pain reflex where you might not even realize it, but your brain gets a signal so quickly, it may even happen subconsciously, that you have pain, and then the muscle gives out as a reflex. So it could be a pain reflex that is buckling, or it may be because of a lack of quadriceps strength. And so this procedure would not help or make worse either of those either of those things. Yeah. Yeah, it doesn't. Remember, we are purposefully avoiding being close to any motor nerves. These nerves are purely sensory. These are just the ones that carry the pain signal, but they don't do anything for muscular strength. So a lot of times after somebody's had an ablation, I'll say, "You feel that?" And they'll say, "Yeah." You know, just to reassure them that, okay, we didn't do anything to your sensation. And then I'll have them straighten their knee and hold it, and I'll push down. It's just as strong as it was afterwards. And I'll say, "Do you see? Your knee is still strong." So I think that helps to reassure people and that's where it really becomes important to remember that different nerves carry different signals. This is purely addressing sensory nerves. Any other questions?